Hi, welcome to Glenohumeral Gurus, a podcast for clinicians with an interest in shoulder pathology. I'm your host, Margie Olds, and it's a pleasure for me to bring you these podcasts. The aim for the podcast is to deliver some clinically relevant content for you. I plan to interview people from all over the globe and talk to clinicians and researchers and anybody with an interest in shoulder pathology so that we can learn how to help these people better. So settle in and enjoy the podcast. Hey, welcome back to the second part of this podcast where Edel Fanning interviews me about the details of shoulder instability. I hope you enjoyed the first section where we talked in detail about strategies of how you could manage the role of physiotherapy and the toll that it takes on you. But this session is about the details of shoulder instability and some tips and tricks that I use to manage my shoulder instability patients. So I hope you enjoy.
And I'll move on to some clinical questions now, if that's okay. And again, some of these are arising from some of your wonderful podcasts. And I've been connecting with you more recently because we've got some exciting projects coming up that we'll hope to chat about at the end of the podcast. But I would love to discuss a little bit around the anterior cuff and what are your go-to. I think I mentioned in the last podcast, when it comes to the anterior cuff, it's probably, and I see it because I see a lot of allergies. It's the one time I certainly do see it. And we know from research out there in some more region, it isn't always back to where we think it is when they're going back. And what are your go-to ways? Have you got a preference? And have you got a framework in how you challenge that and how you engage it? Do you try and optimize one part of the cuff versus the other? Is it purely based on your objective assessment, your subjective assessment, or so I'd love your thoughts around that.
So typically what I've seen over the years of thinking about cuff and how that works and instability and how they work, I typically see that the people with posterior instability are weak in their posterior cuff. So this is how I've been thinking maybe for the last 10 years or so. People with posterior instability, they're weak in their posterior cuff. If you strengthen them, their posterior cuff isometrically and build them up, then take them up overhead, then, and I'm talking about people with posterior instability who flex and sublux maybe at 30 degrees, that then if you were to create some kind of buffer for them, perhaps that's what I'm doing, then they can flex and not sublux. And that's been my experience. And similarly with anterior instability, I see that they are weak in their lift off. I look for subscap. I don't think enough people look for subscap. Maybe now I look too much, but it's also very under researched because you need fine wire EMG to see it. And so the number of papers that have looked to look at what your subscap is doing is way less than you would see for the posterior cuff. So I think I'm backing the underdog maybe is a bit underrepresented in the research. And so similarly, I've been looking for that lift off, looking to see that they're weak there. Typically everybody I see with anterior instability will be weak. If you put their hand behind their back and look compared to the other side, they will have weakness. And so then I've also, thinking along that subscap theme, I've been thinking not only for strength but motor control, because I think they are both important. I used to approach everybody from a motor control perspective, but in some cohorts that's really difficult. But if you palpate their subscap and then wind them back into external rotation, you can feel their subscap contract. And what I've seen is people who have pain back there. So say you have a positive apprehension with either pain or fear or let's call that a positive apprehension test, because you have some positive apprehension. When you can teach them to control their subscap all the way back, then their apprehension is modifiable. So that has reinforced my belief system around managing that. Yes, these people are also weak in their posterior cuff overhead, but typically the anterior cuff below shoulder height. So that was my current thinking until I started delving into your work. And then, because we know from some of your work that their weakness is in outer range or inner range of the muscle. And so now I wonder if the instabilities are just weak in their inner range. And now when I thought I was looking at subscap, I'm looking at, yes, of course, I'm looking at subscap, but it's inner range and it's posterior cuff in a range of that muscle. And so rather than look, I've been looking at the wrong pattern. So that's currently what I'm thinking about. That's evolving. it's,
Always
that's
evolving.
always
And you
evolving. So
said it's
that's
so
what I'm
interesting.
thinking.
Yeah, and I'm listening going, do you know what? And I do very similar exercises, but probably have, I think about it again, rightly or wrongly, I don't know. And again, even when it comes to testing, like our research, we took supine for a number of reasons. But then it may be different if we prone them. It may be different if
Yes,
we had them in other positions. That's the other thing, isn't it? How it's working
yes,
eccentrically, concentrically. But when, as
yes,
you know, when it comes to research, it's got to be reliable. You got to commit to something, and it's got to make sense for that
yes,
cohort.
yes,
And as you very well know, because you often get, why didn't you do this and this and this? And you're like, yes, but I have to commit. I did think about this. Um, and yeah, and it's really interesting. But say, for example, your thought pattern through, so your MDIs through, say, or if they have a direction specific through flexion, and as you're right, you know, they'll often come out posteriorly, they'll have that lag in the upward
mm,
rotators, you know, and the
yes,
laxity and the lack of control and all of those things. And and I'm always thinking, you know, probably even some of Karen Ginn's work, we know, say, through flexion, the posterior cuff is more dominant than the
yes.
anterior cuff. But again, it's so I think the multi-directional or the direction, you know, the more hyperlaxity, if they've got a certain direction, I often find
What
we'll
I've
have it.
struggled with there, I think, because typically I've gone into posterior cuff or I've gone into anterior cuff. And sometimes I think what happens in those multi-directionals, they are so lax that when you load one side, they shunt the other way. And when you load the back, they shunt out the front. That's been what I've palpated with my clinical skills. And so that's been my clinical thinking. And so then I have put them in side lying at 90 degrees. That's one option. I know ankles would plant them more in closed chain and then progressively load them. So I either put them inside lying at 90 degrees of abduction where there's minimal cuff load, and then I could do circles to look at their coordination, perhaps of anterior and posterior cuff, and get without using the cuff as a rotator. And so similarly, on an side support at 90 degrees of abduction, then they are, you know, you could twist them backwards and forwards, or they could just progressively load in that position. And what I found is by taking even these posterior instabilities into like a 4-point kneeling or some sort of kneeling where you progressively load them. That way
Yeah.
I can get posterior cuff and their scapula and their deep neck flexors all at once. You know, it's really efficient. I don't have to do all the scapular work and all this neck work before I get to their shoulder. Like,
Mhm.
I found that to be really efficient. And that way then I can load these people. Like, we'll talk about these hypermobile contact people. They need loading. And I had this wonderful chat with Benham Leggett about his wonderful work in loading, heavy loading for these hypermobile athletes.
Mhm.
Is they My athletes need extensive loading, and my pole dancers and my rugby players, they may be hypermobile, but they definitely need still those strength and conditioning principles and heavy loading down the line
Yeah.
once I can get their shoulder in their socket.
For sure, and it's interesting. It's sometimes when you have to talk about it and structure your, because often you just do it, don't you? Because you see it all the
Yes,
time, day in day out,
yes.
and you partly really clinical pattern recognition. But actually, when you structure and you talk about it, or you have to structure it and teach it, and I think probably, you know, and I think Anne highlighted there is a difference between, say, your traumatic instability and a weakness, say, in subscap or your internal rotators, likely whether it's a contributory factor from the surgery and the splits through the
Mhm,
subscap and how you manage that
mhm,
versus
mhm.
your motor pattern, hyperlaxity, and how, and I think ultimately it's getting a safe entry level, isn't it? It's
Yes,
getting an
very much
entry level,
so.
get our way in. And I think
Yes,
particularly, and it's, and it may be sometimes like you, I'll put them on their side and I'll give them that compressive force. And I might work more its stability role than its rotatory role. Sometimes I'll get them in prone,
yes.
give them a block and allow them to activate, and that works. Sometimes I
Mm,
put them in 4 point kneeling. I've one at the moment, grossly bilateral instability. Can't even push a door up when it comes out the back. There's no way. I've started to get pretty good control through rotation now. I still can't
yes.
upwardly rotate yet. And there's the hands on the floor, it's straight out the back, so I think it's a lot. That's the fun thing, isn't it?
Yes, but I think you're
It
right, getting that in. Like I typically try to train people so it's difficult but not painful, because then I get that in and I can help calm them, their cognitive system. And so that once you have the in, then you're away, in my
Yeah,
experience.
it
It's
is.
finding that in.
It's the safe entry level, and even when I find when you're asked to see even an athlete or more, it's there's something missing on the smaller stuff, and once you get,
Yeah,
I always think the other stuff is, but that's really interesting, and it sounds like you're, as I said, very similar approaches in some ways, but even
yeah.
the reasoning behind, but that anterior cuff stuff, and just to recap in terms of your go-to exercises for that, what are the stuff that you, and I know it varies. Sometimes you said you'll go through the stability type of role inside
Mm,
lying, where you may
mm.
focus on, bringing it more into extension and back again.
Yeah, yeah.
Um,
So
um,
what I did, like, when I worked, Tim all really helped me pull out all the, he's such a wonderful educator that really helped me crystallize all these clinical patterns into what do you normally do you know? And so that's where I started thinking about, well, that's what I would do for an anterior instability, that's what I would do for a posterior instability. And we published that paper in the Journal of Athletic Training that really helps you walk through these protocols, that you could address motor control or address strength in the anterior and posterior cuff. Sometimes I do them at the same time, and again, sometimes I do one then the other. Depends on the healthcare system that you work in, I guess. But trying to build their strength in subscap, build their motor control, build their differentiation from posterior cuff, from scapula. Never again, because I think inner range is so important that I would never allow them to move their trunk and scapula and external rotators all together. I break that down. But if I think about my practice, it's very part practice identifying the deficits and then layering that up so that they all amalgamate through into function. That's how I think. What's the deficit? This is a deficit. This is a deficit. And not always do I get the crystal clear diagnosis, but if I start treating the deficits, oh, you're weaker here on this side compared to the other side. You can do this on this side, but you can't do that side. This is sort of what I would expect for you. Then it starts to get really clear.
Yes, yeah. No, I think that's summarized really nicely. And I'm always probably the same. I'll always think like maximum support to begin with. If we can, loads of support. It's such a sensory joint, isn't it? Lots
Mm,
of, whether it's
mm,
manual, whether it's with, completely deloading the joint,
yes,
challenging whatever you're finding on testing, challenging its different ranges. And then, as you said, your ultimate is being able to combine all of these things together unsupported, isn't it?
yes, yes,
That they're able to access that full range unsupported under load, and then into
yeah,
obviously under speed and being able to generate force.
yes.
So I think probably, and listening to your previous, we all probably have something similar, even even if
Yeah,
we're
but that's
coming.
why it works, eh? I think that's the interesting thing about these podcasts is listening to different people's approaches, but listening, talking to you now, I realize the similarities of what we
Yeah,
do. And those
for
are
sure.
probably the nuggets. You can add your flavor around the side, however you do
Your
that.
go-to exercises and how you cue those, but it's probably still the
Yes,
same concepts of support, gravity, resistance, load,
yes,
and then
yes,
more, as you said, more into how you're targeting your different strength parameters as you go along.
yes, yes.
No, that's really interesting because I said no, that's certainly I wanted to delve into that. So thank you. And the other kind of clinical kind of little area to kind of explore in around the deltoid.
Oh, yeah.
Because again, I think I heard you chat on, was it with Anne Cools, and
Mm.
your thought of the, like, say for example, if we take your contact athlete and he's post stabilization or she's post stabilization, and when do you add that nice deltoid stuff in? Do you have a set time, or
Yes.
and
And so it was
again,
interesting when I saw your question, because I was like, well, what do I think about deltoid? And maybe I'm probably not thinking about it enough. I tend to really think about cuff and then layer up the exercises, which end up being very deltoid, of course, because you can't not. But
not,
I
yeah.
don't know that I've been targeting it. But when I give people bent over rows, then there's their posterior when they're benching, when they're pushing weight overhead. I mean, you're either thinking anterior or posterior. Maybe after listening to Anne, maybe I don't think enough middle deltoid, but when I
Yeah.
can, absolutely do not allow any of my athletes with scapular dyskinesis to do their lateral raises, So I'm interested, from a deltoid perspective, what else should I be doing?
No, no, and this is, and again, it's probably something I've dealt in and out, because I remember even a long time ago, I was fortunate enough to spend some time with Andrew Jaggy,
Yes,
and I remember having a conversation, and this is probably about 10 years ago, around the role of the deltoid, and should we be maximizing it? I think it's probably one of the muscle groups you see waste very quickly. I'll often see, no matter what you do and how early I've got access to them, between week 2 and 4, that deltoid really goes bulk-wise, post-shoulder
yes,
stabilization, as does the upper trapezius, biceps, triceps, and the athletes will tell you, like, they're like, oh my goodness, this is gone. So
yes.
it definitely, you lose muscle bulk around there, which just shows you, doesn't it? The impact of surgery, injury,
Mm, mm.
and like that. You're always kind of functional, aren't you? Making sure that you're getting back to the functions. Um, but I do play around with it, but I always think you need a fairly balanced cuff to then really low deltoid. Yeah, so like your lateral
That's
raise, that's one of the last ones for me,
yes,
because they end up sore. And
yes,
generally, I have such a small time frame, I can't risk them sore. But like some of the sideline stuff's lovely, isn't it? To
yes,
like I said a guy in that was 6 weeks posterior labral repair. Some of the sidelines, because he's like, my deltoid's gone. Some of the sidelines, so you can do it more anti-gravity or wall assisted, or where
yes. Okay.
the weight
Do
isn't
you think
traction.
you get the buyback from that though? Do you think that is
Do
that
I
like a
get the
head?
changes as
Well,
quickly as
do you get it? Is it worth it? I guess is my question to you,
yeah.
because if you focused on their cuff and then you could layer up their deltoid when they had a stable cuff, do you think that by that early focus on deltoid, it's you get what you need? Do you know what I mean? I guess you wouldn't know
Yeah,
unless
and
you
like you, I
didn't. And then
probably have a good, okay, this is what we're focusing on this week. And a lot of
yes,
it's around unlocking external rotation, optimizing the posterior cuff through range, the anterior cuff through range,
yes,
unlocking full flexion. They're your big kind of go-tos, aren't they? And
yes,
then production, you often find it just comes along once the rest of
yes,
it's balanced. And I certainly find that, but it's probably something I am thinking, only because I certainly see that wasting. And it depends, sometimes you've got some higher level athletes that you've got very early access to.
yes,
I've just got more time with them, so I see
yes,
it, I can think about it. Do you know what? If I've got someone that I've only access, I'm seeing him every two, or her every 2 weeks. No, probably not, because there's other
yeah.
priorities to have enough time frame there. But I think sometimes I've got more access. And then the other group is probably where I think it really has a big role, because sometimes the rotational stuff I just can't get it through, is the more hypermobile.
That's exactly what I was just
Yeah.
thinking. When I
Yeah.
look at
But so
Anne's
much trial
work,
and error, hey?
yeah, yeah, and finding the safe in, isn't it? But if you
Yeah.
think about the role of deltoid and elevating the humeral head, and some of these people that have that inferior instability or laxity component, then
And
that's
then that's where the compressive positions are quite nice, aren't they?
yes,
Mm.
yes. Yeah.
Yeah, and whether that's manually or positionally or whatever. But yeah, really interesting, isn't it?
Isn't it? Isn't it? No, it's been good reflection for me.
And I'm conscious now, I won't keep you too much longer. I've lots more questions here, Margie, but we'll.
We can do rapid fire.
Well, as we said, we've got some exciting things that we're going to work together on. But the other, and probably that I am seeing more in clinical practice, I think Ireland's a little bit like New Zealand. We have huge amounts of collision sports between Gaelic football, hurling, rugby, are the hyper mobile athletes, and maybe not excessively hypermobile, but they may have 115, 120 external, 90
Mm,
internal, quite
mm,
big ranges, and they is scoring quite high in the Baton score, all of those things. And they have a traumatic injury, you do a
yeah.
good bit of bony damage, subsequently have it repaired, you bring them
Yes.
in, and the other cohort is we often find this in your younger contact athletes, and then they're hypermobile as well, and how we protect these against further events. So recently, I had a case that came to me. She had bilateral lateral J procedures,
Mm,
and a camogie player, and bilateral lateral J procedures. One has dislocated 4 times over the, still playing high level camogie, has dislocated 4 times over the lateral J. And lucky
yeah.
to escape bony damage. It just shows you the level of
Yeah.
ability, doesn't it? And are we doing good enough for these? And I'm
So
finding that,
challenging though, eh?
yeah,
Because we
and I
know
don't think our
that.
return to sport tests are identifying it.
No, I think what we know about that's a risk factor for failing Latarjet is that, and we're on a journey with these Latarjets, aren't we? But
Mm.
hypermobility is a risk factor for failing a Latarjet. So some of that is, well, should they have had the Latarjet in the first place? Do you know? And that's a question as we begin to evolve who it suits and who it doesn't. Because just having being a contact athlete and having a dislocation in my eyes doesn't make you suitable for that, because we know that if you have bilateral dislocations and have hypermobility, then the risk of you failing your Latarjet is much higher. So there's really good evidence around that. And so some of that is then what we are given from our surgical colleagues then to try and manage this case. Again, I think it's around that the Latarjets are difficult because then you're not working with normal anatomy there, the way. But I think it's around that inner cuff strength. It's about building their inner cuff so that people don't dislocate typically in contact and collision in mid-range. They dislocate at outer ranges, and so that's where they need a bulletproof cuff layered up by a fully solid deltoid with a stable scapula and great kinetic chain links that all work, quickly. So it's challenging, though, a challenging area, but some of the challenges is not all ours, because we know about the risk factors for failure. So, yeah.
And I think the surgeons struggle as well, don't they?
Yeah.
Because they still want to play, still want to
Yeah.
play, and
Completely.
yeah, because it is so important, isn't it? Such a social, a big
And
part
it's
also.
so, and that's where we made those shoulder braces to try and limit range, so you can tie them down so that people could still play, but in their safe range. That was one of the drivers behind the bracing, was to say, well, yes, you could play, but if I could limit your risk and your exposure in these different places, then maybe that makes that okay, and you're
Mm.
doing whatever you can then to mitigate risk. And that's where some of that confidence and fear stuff has come from as
Yeah.
well. How could you address that? Because we know that's a risk factor. What could we do about that? It's really thinking outside the box for your athlete, and
Mm.
really individualized care, I guess.
It is. It is, absolutely. And what are your thoughts around return to sport testing for this? Do your tests change if you've got someone like this versus, and this is something I'm probably, because I am seeing it more
Mm.
around this versus around someone, a contact athlete that isn't hypermobile? Do you make any
Look, I
alterations?
think, but at the end of the day, and so in my role at the minute is not in a space where I see elite athletes week by week by week. Do you know? So I can't like document your change. The testing that I do for return to sport now is one off. Do I think you're ready to play? And the demands of the sport for me dictate the test. So whether you're hypermobile or not, you're going into that same environment as so you have to be able to perform, and I had a really interesting case the other day with a young unstable athlete who's of course come to see me like 2 weeks away before the final trip from his school for first 15. I mean, if I could count the number of times that the team needs me and I have to play like all those things. And again,
Yeah.
that's where the shared decision making is really useful, because look, can you do this? Look, you can't do that on this hand, you can do it on the other hand. I hope your opponents are smaller than you, is what I said to him, because it's
I
such a
hope you.
yeah,
Yeah.
look, because are you ready to go? No, look, you're not. You don't have. So I typically would measure the handheld dynamometry, because that's what I have available to me in the clinic, and I can do that quickly and easily. Looking, really, I just look for external rotation strength, and then as a percentage of body weight, we know is really useful. But that way, I can quickly compare sides. Look, this is your strength here. This is not where that is, and sometimes I have to look right up into those different positions to see that. But yeah, they don't always make the decisions that I would make for them.
Yeah, it's tricky, and there's just so many factors influencing it, isn't it? But
Yeah,
yeah, certainly. And what I've probably been finding is, say, we have some key tests that we'd like them to optimize, they
yeah,
pass,
yeah,
you know. Part of that is because maybe some of the research we're looking at is a bit more standardized. But actually, if I have them, I will take them even to if they've 110 degrees, if I can keep them as a kinetic threat range, I'll test
yes,
them throughout range. But I also think, yeah, that there's so much other probably factors other than just the control and strength, that even when we have
yes.
that, and it might be
But it
that they
has to
have
be
to,
quick, doesn't it? Like the
yeah,
guys that I
we
see,
have to
they
even,
dislocate in the blink of an
yeah,
eye. And so you have to be that unexpected force that blows your arm backwards. When I tackled for a guy and I didn't quite rotate enough, or I didn't quite get this or that or whatever, and next thing my arm is being forced behind me, then you need that force. And that's where I think the testing that I do for people with anterior instability is different than posterior instability, is different for an overhead thrower when their demands are different than a contact collision athlete. I think that's very, very important. And so maybe for your hypermobile contact athlete, it's about being right back in that vulnerable range, because that's where he's going to be vulnerable. And so
and you know,
really looking at that.
yeah, and that's even another whole conversation, isn't it? Around all of that testing. But yeah, no, it is and as you said, even no matter how good you get it, I think some of it, as you're saying, as you mentioned, how they play, you know. We'll
Yeah.
have
And
some that
then the
actually
decision making, like some of
that
these,
is,
the
yeah.
decisions that they make on the field, some like lately I've said the number of the contact athletes that I've seen, I often, well, why do you play? What is it and some of it is the camaraderie, and in New Zealand, that's a massive social identity. Some of it is I like the big hits, and so if you're out there looking for big contact, things are going to happen, so trying to help kids make smart decisions and be smarter decision makers on the field, that's such an
Mm,
important part of injury
absolutely.
modification, because if you're quicker, then you don't get left
Yeah.
behind. You're not reaching for a guy that as he blows your arm behind you. Do you know? And I think that sort of leads us into what we were talking before about that supine, the moving apprehension test, and what it is trying to develop then anterior support and trying to get a measure of that as you take your arm behind you, because that's where my anterior instabilities are having having their recurrence. It's as their arm gets behind them. And so the idea was to lower their arm in different positions so that we could load their anterior cuff, load their anterior structures to see if that was the same as the other side. It turns out you're really vulnerable up here in end range flexion. And when you're hypermobile, you're at increased risk there as well. So I think there's more work to be done in that space too, because sometimes we see that with Ben Ashworth's test in prone, but that doesn't always equate to, okay, now push as hard as you can. You're responding to a auditory cue. None of my players are like, put your arm out here. Okay, I'm going to blow past you now. It never works like that. It's in response to perturbation. So and if you think about then the motor control strategies around responding to an auditory cue versus a physical perturbation, they're quite different around your central nervous system and the decisions you make and all those programs that happen. There's so much to think about, isn't there?
There is, yes, and as you said, all you're always trying to do, as all of us are, is trying to optimize everything, and
Of course.
having, isn't it, having, if from a rehab side. But I absolutely think there's so much value in, particularly these young contacts, so many other elements, like, we know, early specialization, you're
Yeah.
more risk for injury, that we're promoting this in the young contact athletes, lots of, variety in sport. And I won't delve into it because we'll probably struggle for time around the growth plates, how the males
Yes.
lag behind the females when it comes to the anterior glenoid, all of these things, and how detrimental some of those injuries are. And then playing cleverly, you'll have a young lad that comes in that clearly, you could struggle within a prop position because of certain reasons, and all of those kind of things to have a think about.
Mm.
And I think sometimes the really high level athletes can be very good at that. I recently had a case of a reoccurrence under the ladder, Jay, and they, quite a small player, and he's like, in the poach position, if you caught out with a long arm, he can't afford to go again. You've gone in through
Wow.
subscap twice, he really can't. And how, he's so quick. His change of direction is phenomenal.
Yeah.
Why he plays at the level he does, but he just gets out of the race. He gets it. He knows not to put his arm in that position.
Yeah.
And it's all of those elements, isn't it, to try and not just the rehab and not just the surgery, and
Yes,
you
it's all
know
those things. And sometimes
all
I
of those
think
things.
like the number of promising young players
Yeah.
I've seen come through, those 16 to 20-year-olds who are on the cusp of breaking through into contracted positions where that's their professional job is managing them as well. That's where we talked before about burnout and responsibility. Oh, I find there's so much to help them with in that space that is
Mm.
potentially life-changing for them,
Oh,
at that.
completely. And
So
unpacking that in terms of how devastating a shoulder, because it's the most common, we've had, some good people in Ireland look at some of that stuff, and
mm,
the shoulder dislocations are your biggest, Teresa Leahy, and she's done some really nice work in the schoolboy cohort, showing some of
yeah,
this stuff. Shoulder dislocations are your biggest injury in all of schoolboy rugby, and then how that. And also we have the issue of playing out of age,
yeah,
a huge difference within a year, but like 16-year-olds going up to 18. And I think once you've had a shoulder dislocation at a very young age and you're playing contact sports, incredibly difficult because the risk of reoccurrence is incredibly high, no matter
yeah, and
what.
your chances of making it through to a
Yeah.
contracted paid position gets much less.
Yeah,
So
and
really,
then you realize how little impact we have on that kind of thing, and yeah, so
yeah,
many, such an evolving space, isn't it?
yeah, yeah,
Thank
yeah.
you so much. I'm conscious time wise that I don't keep you too long, and as I was saying, we're going to team up, aren't we? So we'll
Oh,
get to
I'm
discuss.
so excited. So yeah, I'm coming over to Europe. I'm really enjoying these connections with you, Adele. It's super fun. So I'm over in Europe in September for CSIC for the conference, and you are also keynote at the conference. And we're like some like double team. But then you've invited
Yeah.
me to Ireland as well. So yeah, I'm coming with my husband, and we're
So I'm
super
so keen to
super
learn from you.
excited.
I'm delighted now that you accepted. So we're going to do a little bit of a tour, a weekend tour of Ireland. We're going to nab you before the second conference, aren't we? So the 14th and 15th of September in Ireland, we are coming. And we're hoping to do one in Dublin and one then perhaps in the west of Ireland. And we're going to cover because, as I was kind of mentioning, similar to New Zealand, and I think we probably connect because we see very similar patients, lots of contact sports. So we're going to cover a lot of rehabbing the contact athlete,
Yeah.
all from instability through to optimizing performance, aren't we? From
Yeah.
glenohumeral joint instability, hypermobile, acromioclavicular joint, and we're going to share thought process, how you might do something differently, how we and
Yeah.
hopefully in a way to help lots of clinicians over this side.
Yeah.
So really fantastic opportunity because it's rare we have you this side of Europe.
Yeah,
So
I'm so excited, and I'm really
don't
looking
miss
forward
out,
to,
people.
yeah, digging more into and learning from you. You know what you do different than me, what I do different than you, and it's just the 1 day course, isn't it? A 1 day on the
Yes,
Saturday, and then
yes.
you're taking me somewhere else for another day.
Taking you down to show you a bit of the west of Ireland, and I know your ears are keen to tour, so we're gonna split it up. But yeah, we'll try and hone as much as we can in the 1 day,
Yes,
and hopefully it'll be really useful in terms of trying to people can optimize our pathways of what we both do,
yes,
to really optimize probably I think certainly the most common sporting types of injuries
yeah.
you often see in Ireland. So
And I think what will be useful for clinicians from that, because in my experience, the more tools you have in your toolbox, the more you can deal with the patient in front of you. So sometimes what I might do might work for a patient, sometimes what you might do might work better. But if the clinician can see both of those, I think it's a fabulous opportunity. So
so we're doubling up on 40 plus years, are we?
yeah,
Of experience of treating shoulders. So we'll hopefully people will enjoy it. And I know I will
yeah,
anyway. So
yeah,
I
yeah.
thank you so much for that. And do you want to go through how people might register for the course?
So our plan is that then there will be some links that we'll put up, that I can put a link then in this podcast, and then on your social media, my social media, we can link for people can register for the course and then into your payment system so they can pay then in euros. So I think if I put the link up, we'll get that all sorted so people can register. The spaces will be limited, and it's just those days, so people should get themselves organized because it will
Yeah.
be
And we say a
will
one-off
be tight.
opportunity of having you really. So amazing. And yeah, the links will be a link to this podcast. And then if anybody's struggling, reach out to us. I'm info@sportsshoulderrehab.com, and Margie is
Margie
what's
at
your
Flawless Motion is probably the easiest way to get hold of me, Margie at
yeah.
flawlessmotion.com. So yeah, people can get in touch, and then we can have more chats in person in Ireland. It's super exciting.
And thank you so much for allowing me to come back in and ask the burning questions. And I learned lots there, and I really appreciated your openness around, all the early stuff and the kind of stuff I think all of us as practitioners go through.
Yeah, it's a journey, isn't it? And I think being kind to yourself along that way is really
It's been often
important.
a wonderful journey and a really privileged journey, but also can come at an expense sometimes. So as you say, I
Yeah.
think we all need to just make sure we look after ourselves and make
Yes.
changes if we need to in our careers, and still while trying to optimize, the outcomes with our patients and everything.
Yeah. Yeah, cool.
Thank you
Hey,
so much.
well, thanks for being such a wonderful host for me. That was really nice to be on this side of the fence. I really enjoyed that.
Oh, thank you. Yes, and it was my first time as a guest podcast host, so thank you so much.
Thanks for joining us for today's podcast. I hope you've really enjoyed this content. You found some clinically useful tidbits, and some of the content has been thought-provoking. Don't forget you can follow me on my social media for some more up-to-date content. If you're looking for a shoulder brace, you can check that out via our shoulder braces on flawlessmotion.com. And if you wanted an online shoulder course, then I have a range of shoulder courses, through from an introductory shoulder course through to return to sport and a shoulder instability course. You can access these courses on margieolds.com or flawlessmotion.com. That's flawlessmotion.com. And every course comes with a complimentary question and answer session so we can drill into your understanding of the key concepts of the course. You can also join our Facebook group, Glenohumeral Gurus, and follow along for the conversations and discussions on this page. And otherwise, I look forward to you joining us for the next podcast. Thanks for your time. Until then, stay well, take care.